Okay, good morning, everyone. We are starting new lecture series today as Academy of Palliative Medicine lecture series. Now, I will request Naveen to say a few words about this lecture series because Naveen is the brain behind Academy of Palliative Medicine. And then I will introduce the speaker for today. So Naveen, can I request you please say a few words about this lecture series and why it is important to attend for everyone throughout series?
Yeah. Good morning, madam, and good morning, everyone. Um, this lecture series was initially started by Dr. Sushma
Hello,
Bhatnagar.
Naveen.
Can you hear me? Hello?
Yes.
So we can hear you. So,
Can you hear me?
yes, so
Okay. Madam, can you hear me?
Yeah, I can hear you now.
Yeah,
Okay, go ahead.
right. So, this lecture series was started by Dr. Sushma Bhatnagar as part of the Indian Association of Palliative Care in the very early phase of COVID, and which we did not stop, and it was ongoing. Right now, it is again done by the same team who are conducting the lecture series right from the COVID time for last 2 to 3 years. Only change that's happening is that we are segregating all the educational initiatives of IAPC under the Academy of Palliative Medicine. Academy of Palliative Medicine is part of the Indian Association of Palliative Care that would specifically deal only as for all the educational activities. Academy of Palliative Medicine is not an independent entity, but part of the IAPC. So Dr. Bhatnagar is the chairman of the Academy of Palliative Medicine and the president of IAPC. It's just for the convenience sake to have a very streamlined process. We are bringing all the education activities under the Academy of Palliative Medicine. And again, it will be very much part of the IAPC also. And the purpose here uh, to have this initiative is that at some point of time, all education activities that's happening either at a specialist level or at the generalist level, we want to bring it in one forum, create a repository of all the activities that's happening. So we have taken up a few activities apart from this morning lectures. And then website is in the development, and a lot of these uh, work that's going on will remain as a repository for a ready reference. So with this, I would ask Dr. Bhatnagar to take it forward as she is the moderator of this session.
Thank you, Naveen. Thank you very much. And so this lecture series, which Naveen with a few more people with Naveen, they have designed. We will have 7 sections. And so we are starting first section, that is symptom management. And whenever we are managing symptoms, it is very important to take history properly and do physical examination. And I always say to residents that without proper history taking and without doing examination, you will not be able to treat patients. So if your patient is not getting relief with the symptoms, this means that inadequate relief means inadequate uh, knowing about the patient. You have not learned a lot about the patient. You have missed something in the history, or you must have missed something in your assessment. So we are not talking about assessment today. We are talking only about the history taking and physical examination. So for this topic, we have chosen one of our third year PG student, because by this time they should know how to take properly history, plus how to do physical examination properly. So the Revathy is our third year PG student. She will explain you about the history taking and physical examination, what exactly we should definitely do, and what are the important salient features, because whole of the things which we won't be able to cover in 40 minutes, but I think she has tried to cover all important aspects of history taking in physical examination. So, Revathy, please start your lecture, and everyone, please write down your questions in the chat box. We will answer at the end.
Thank you, ma'am. Thank you. Ma'am, am I audible clearly?
Yes, we can hear you.
Okay.
Yes, you are audible, Revathy. अच्छी तरीके से सुन रहा है, कोई बात.
Okay, ma'am. Thank you. Good morning, everyone, respected faculty and my dear colleagues. I would like to welcome all of you. The topic of presentation today is history taking and physical examination in holistic palliative care. The moderator for today's topic is Professor Sushma ma'am. I would like to thank her. She's the HOD of our department, and I would like to thank her for the guidance towards the preparation of the presentation. Moving on to the class. First, I'd like to briefly go through the definition of palliative care that was recently given by WHO. It is an approach that improves the quality of life of patients and their families who are facing problems associated with life-threatening illnesses. It aims at preventing and relieving suffering through early identification, impeccable assessment, and treatment of pain and other problems, physical, psychosocial, and spiritual. So, despite modern advances, history taking and physical examination are still essential skills to approach a diagnosis. It also helps the physician to establish an initial rapport with the patient. As the definition clearly suggests, patients of the palliative care setup suffer from life-threatening illnesses. That is, in most of the cases, they already have an established diagnosis when they present to us. In history taking and physical examination, holistic palliative care, we need to do addressing of physical symptoms, which could be pain, breathlessness, fatigue, nausea, and vomiting. And we also need to give an equal emphasis on all the other domains, which are psychosocial, spiritual, financial, and so on. We need to explore beyond the traditional domains for holistic palliative care. In a previous disease-focused model of care, there is focus solely on the physical symptoms and body organ systems, followed by laboratory tests and procedures to come to a diagnosis. But in holistic palliative care, in addition to all the routine evaluation that includes the standard elements of medical history and physical examination, it encompasses physical, emotional, intellectual, social, cultural, and spiritual well-being. And we need to establish goals of care. And it is always an interdisciplinary approach. As palliative care physicians, we tend to have more of emphasis on quality of life rather than quantity of life. So the skills that are absolutely necessary as a palliative care physician and the skills that will aid us in our day-to-day practice is clinical knowledge, as is the case of any physician. And then we need to have good communication skills. Palliative care physicians need to be open-minded, and we need to be empathetic. And it has been clearly mentioned in the Oxford Text of Palliative Medicine 6th edition regarding exquisite empathy. Exquisite empathy has been defined as a highly present, sensitively attuned, well-boundary, heartfelt empathic engagement. And this kind of empathy will protect the physician against compassion fatigue and burnout in future. And palliative care physicians also need to have good grieving strategies to them, because we are physicians who are frequently exposed to frequent and multiple deaths. So we need to have grieving strategies. Few of the approaches include departmental debriefings, journaling, and also post-bereavement family visits. The 4 aspects of symptom management in palliative care include: the first one is medical. That is, we need to assess the cause of the symptom. The next one is rehabilitation. Once we find out the cause of the symptom, we can try to rehabilitate as and when possible, but often this is limited in case of end-stage chronic diseases. The next aspect is palliation. That is, whatever symptom that is there, we try to alleviate those symptoms as much as possible. And then the 4th aspect is end-of-life care. That is to provide comfort and take into account the patient caregiver's wishes. So, briefly, palliative care aims to relieve suffering in all stages of disease. It may be provided along with curative and life-prolonging treatment, and not just limited to end-of-life care. It also extends to families' bereavement period. Before going on to history taking and physical examination, we need to know in which patients we need to include palliative specific criteria. We need to see which patients require palliative care assessment. So Weissman et al. Has published in 2011 primary and secondary criteria through which we can see what patients who come to the hospital might require a palliative care assessment. The primary criteria they have, as they have published, include the surprise question, which we all know, whether the physician would be surprised if the patient would be alive within the next 12 months, and there is history of frequent admissions, or there are difficult to control physical or psychological symptoms if the patient has complex care requirements, or if there is a decline in function of feeding intolerance. The secondary criteria includes admission from a long-term care facility, an older patient or a patient with cognitive impairment, a metastatic or locally advanced incurable cancer, chronic home oxygen use, out-of-hospital cardiac arrest, current or past hospice program enrollee, limited social support, and no history of completing an advanced care planning or discussion, discussion or document. In the study, they have mentioned that the primary criteria are global indicators that represent the minimum that hospitals should use to screen patients screen the patients who are at risk of unmet palliative care needs. And the secondary criteria includes more specific indicators in which the patients have a high likelihood of unmet palliative care needs. Coming on to the common symptoms encountered in end-stage illnesses. This has been published by Moens K. in et al. In 2014, and not just included non-malignant malignancies, but also all chronic non-malignant diseases as well as AIDS. The most common symptoms include pain, breathlessness, nausea and vomiting, constipation, altered sensorium or confusion, fatigue, psychological stressors like depression, anxiety, stress, insomnia, diarrhea, and anorexia. The assessment of symptoms during history taking can be done with the help of a mnemonic Socrates, where the abbreviation stands for site, onset, characteristics, radiation, associated symptoms, timing, exacerbating and relieving factors, and severity. And to add on to that, we can also add, in case of a history of pain as a symptom, a history of analgesic use, and the efficacy of the ongoing analgesic, if any, and history of trauma or surgery. There is another mnemonic that will help in taking a history of various symptoms, that is the OPQRST, which abbreviates to onset, palliating and provoking factors, quality, related factors or response to previous treatment, severity, site, and temporal changes, and also in addition how the patient suffers or how the symptom burdens the patient. There are various tools that are available to us for symptom assessment. To enumerate a few: revised ESAS, the condensed MSAS score, Rotterdam symptom checklist, MD Anderson brief symptom inventory, and symptom distress scale. We routinely use revised ESAS in our practice, the Edmonton symptom assessment system, in which we grade a range of symptoms including pain, tiredness, drowsiness, nausea, lack of appetite, shortness of breath, depression, anxiety, best well-being, and other problems, if any. And we grade it from a range of 0 to 10, 0 being no symptom and 10 being the worst possible symptom. And in the next side of the revised ESAS, there is a body chart in which the specific area, exact area of pain that the patient suffers from can be marked. This is the ESAS ESAS score for symptom assessment. All the tools that we have seen, a range of symptoms can be assessed, but there are tools that help us in assessing and grading a specific symptom. For example, the NRS or the PISA scale, FLAC scale, or Wong-Baker phases for pain, MMRC and NIHA to assess for dyspnea, the confusion assessment method for confusion or delirium, fatigue severity scale that is used for assessment of fatigue, and the Bristol stool form commonly used for assessing constipation. We routinely use a numeric pain rating scale in our practice, where 0 corresponds to no pain, and 5 corresponds to moderate pain, and 10 corresponds to worst possible pain. NRS can be used in verbal children and adults. The PISA scale is commonly used in illiterate adults, and the FLAC scale that has been mentioned earlier is used in non and pre-verbal children. This is the pictorial representation of the MMRC dyspnea scale. Whenever the patient presents with shortness of breath, we try to grade them according to the MMRC dyspnea scale, where grade 0 is patient is not troubled by shortness of breath unless he or she does strenuous exercise, and grade 4 corresponds to very severe dyspnea and cannot leave the house. This is a chart showing the Bristol stool chart. Now, we'll come on to a clinical scenario, and we'll go through the various aspects of history taking and physical examination through the clinical scenario. Mrs. X is a 52-year-old female. She was diagnosed with carcinoma breast in 2014 November, when she was evaluated for a small lump on her right breast, and for which she underwent surgery in the same year. The histopathological examination was suggestive of invasive ductal carcinoma, and after surgery, somehow she lost to follow-up. In 2020, she presented with complaints of shortness of breath and generalized body aches, which was predominantly the body aches were generalized, but predominantly she complained of pain over the mid and low back, and also complained of weakness. PET scan at this time was suggestive of metastatic lesions in bilateral lung, extensive axial and appendicular skeletal metastasis, and the patient was started on chemotherapy plus immunotherapy. So, from this brief history, presenting complaints can be explained as pain is a patient is having pain mid and lower back since past 1 month, and there is shortness of breath for 2 to 3 weeks. The complaints and presenting complaints are to be recorded in a chronological order with duration and in patient's language. So, as per the clinical scenario, we can briefly explain the history of present illness as following. Patient was apparently well 1 month back when she developed complaint of pain over mid and lower back, which was insidious in onset, gradually progressive, dull aching in character, severity of pain more at night, and exacerbated with movement. And the patient gives history of taking over-the-counter pain medication, and she has adequate relief. She used to have adequate relief with those medications initially, but currently she has an NRS of 7 to 8 or 10, even with those medication. And it is important to enumerate few negative history at the time of history of present illness itself. For this patient, she did not have any history of trauma or fall. There was no complaints of bowel or bladder incontinence, and there was no complaint of loss of sensation on her lower limbs. And regarding her second complaint, the history of present illness would go as such. Patient also complains of gradually progressive shortness of breath, noticed by the patient initially 3 weeks back when she developed difficulty while doing activities of daily life, but not associated with diurnal variation. Currently reports of some relief in upright position. Breathlessness at rest, she can be graded as MMRC grade 3. There is no history of fever or cough with expectoration. So the symptoms, I've tried to enumerate the symptoms using the mnemonics which we have gone through earlier, and explain each of the point through the history of present illness. At this point, I would like to quote Mary Baines. She is a British palliative care physician, and she's a pioneer of the palliative care movement alongside Dame Cicely Saunders. To quote her, "One cannot help a man to come to accept his impending death if he remains in severe pain. One cannot give spiritual counsel to a woman who is vomiting, or help a wife and children say their goodbyes to a father who is so drugged that he cannot respond." So at this point, evaluation and management, at least partial management of acute symptoms, may be necessary before proceeding to the rest of extensive history taking and examination. That is in cases when patient presents with a severe pain and NRS of greater than 7 in initial assessment, or when the patient is dyspneic at rest, or when they are having recurrent nausea and vomiting. After managing or partially managing those symptoms, then we can proceed to rest of history taking and physical examination. The past history includes history of past illnesses, any history of surgery, and history of allergies. Family history includes history of similar illnesses, consanguinity, or communicable diseases. Personal history includes comorbidities, addiction, sleep, diet, appetite, bowel and bladder habits. And treatment history includes the history of the present illness and use of any ongoing drugs. Treatment history often in our patients are very extensive because they would have been suffering from a chronic disease for the past many years. So we often tend to have an extensive treatment history in our patients. But among all these, I would like to slightly explain more about family history. The standard elements of family history includes, as I've already enumerated, health status of other family members, any history of similar illness in the family, history of consanguinity, history of diseases that are inherited or communicable diseases. And this is a pedigree chart that we use to depict the family history. But how was it more important to us? The importance of family history in our practice is that it can be used as an aid to understand the family's dynamics, to identify the key decision maker in the family, and which will further help us during family meetings and when there are decisions to be made at the end of life. It will help better communication between family and clinician. The picture has been adapted from Oxford Text of Palliative Care. In addition to the normal pedigree chart, it has been clearly mentioned who the patient is, what the speaking language is, and the chief caretaker or the spokesperson in the family has been clearly indicated, so that whenever clear decisions has to be taken or whenever family meetings has to be done, this patient can be involved actively in the process. Coming back to the clinical scenario, so the patient came with all those symptoms. Once a patient came with those symptoms, in order to manage those acute symptoms, we admitted them. And initially pain was managed, and she had severe pain. So pain was managed with IV opioids and adjuvants. And after 30 minutes to 45 minutes, she reported her NRS to have reduced to 4 to 5 or 10, and she was no longer wincing in pain. But at this point of time, she became emotionally labile and starts crying uncontrollably. So we would expect her physical symptom has resolved, and she herself is reporting it to have resolved to more than half of her initial complaint. But why is she crying uncontrollably at this point? So in order to assess these, we need to have the other tools that are available to us as palliative care physician. And this is where the other components of history taking becomes useful to us. This includes a psychological history, social history, and spiritual history. I'll be briefly explaining each of these. In psychological assessment, we mainly assess for depression, anxiety, delirium, and stress. The factors that may increase the severity of psychological stress as evidence-based is rapidly advancing disease, uncontrolled pain, patient is already on medications like glucocorticoids, metabolic abnormalities, any impaired cognition, financial distress, and pre-existing psychiatric illness. The psychological assessment tools mainly used include DAS-21, which focuses on depression, anxiety, and stress. And we have a distress thermometer and problem list, which also focuses on depression, anxiety, and stress. Another commonly used tool is the hospital anxiety and depression scale, where depression and anxiety are being assessed. We commonly use routinely in our practice the DAS-21, in which we have 21 questions through which a patient is graded for severity of depression, anxiety, and stress, and using a scoring system, a severity that is normal, mild, moderate, severe, or extremely severe can be assessed. And if the patient at the time of our routine assessment, if we find any patient to have severe or extremely severe depression, anxiety, or stress, we can use the help of experts like psychiatrists or psychologists at this point. Next is social assessment. In social assessment, we need to briefly explore and enumerate details such as the primary caregiver, earning members in the family, the dependent children, impact of disease on the activities of daily life of the patient, financial security or the socioeconomic status, living arrangement, and whether the patient requires use of equipments like wheelchair, caregiver needs of the patient, the patient's caregiver's needs, and healthcare access. The socioeconomic status as is routine helps us in provided if the patient comes from a poor socioeconomic background, then it can lead us to believe that patient might suffer from malnutrition and there is increased risk of infection or infestation. And if patient provided if comes from an affluent society, there are risks for diseases like obesity or dyslipidemia, and socioeconomic status also help us to see if the patient is affording investigations and treatments. But there are specific implications of this in palliative care. Patients with advanced illnesses and caregivers frequently experience financial strain, and once we assess the educational status, it can be a way for the physician to identify a method to communicate or a way to initiate communication with the patient and caregivers. And economic burden profoundly impacts the healthcare decisions. That is, because of financial strain, there are cases when when it might lead to under treatment, and there are cases when, because of affordability, inappropriate treatments or procedures are done. The modified Kupuswamy scale, this as has been latest updated in 2019, in 3 domains: occupation of the head of the family, education of the head of the family, and monthly family income in rupees. Scorings are given based on these 3 domains, and based on the scoring, patient can be classified as upper middle, lower middle, upper lower, and lower socioeconomic class. But this is a method of quantitatively assessing assessing the socioeconomic status. But in our practice, we also need to qualitatively assess the socioeconomic distress in the patient. Some questions that might help us as physicians to elicit these would be: what kind of help do you need at home? Has your illness created financial strain on your family? Do you worry that you may become a burden to your family? All these questions might aid us to qualitatively assess whether they are in severe socioeconomic distress or not. Coming on to the spiritual assessment. For spiritual assessment also, there are various tools that are available to us. Spiritual assessment, spirituality is not exclusively the religion of the patient, and even atheists will have their own spirituality. So the various tools are FICA, Spirit Tool, and the Hope Tool. We are routinely using the FICA tool in our practice, and it abbreviates to F stands for faith and belief, where we are eliciting questions like: do you consider yourself spiritual? Excuse me. Sorry. Do you have spiritual beliefs that help you cope? And in importance, what importance does spirituality have in your life? What role does spirituality play in your healthcare decision making? Community. Are you a part of a spiritual or religious community? Is there a group of people you really love or are important to you? And in address, how would you like to address these issues in your healthcare? These are the questions upon abbreviation of the FICA tool. And in spiritual assessment, patients often probe us with questions like: why me? And have I done any sins in my past life? So these tools will guide us as physicians, and will guide us in taking a united decision with the patient and caregiver consensus. And during a spiritual assessment, we often might need assessment of a trained counselor or a chaplain. Moving on to general physical examination. In holistic palliative care also, we routinely do whatever that is traditionally being done. In appearance, we look for demeanor, whether the patient is distressed or is agitated. We look at the facies, whether they are comfortable, gasping or wincing in pain. And we look for the posture and consciousness and orientation. We assess and built-in nourishment. In our practice, we are specifically using a tool, the subjective global assessment. And performance status is very important in our practice. For oncological patients, we are using the ECOG-PS tool, and KPS, the Karnofsky prognostic score, can be used for both setups, oncological and non-oncological. And we go through vitals of the patient: the pulse, BP, temperature, respiratory rate, SpO2, and the 5th vital, that is pain. This is the subjective global assessment. Here, we go through all the domains, that is weight change, dietary intake, gastrointestinal symptoms, functional capacity, physical findings, and disease and its relation to nutritional requirement. And a rank is determined by the clinician, and this is a subjective ranking. And based on the overall subjective global assessment, the ranking can be either A, in which patient is well nourished, B, moderately nourished or malnourished, and C, where the patient is severely malnourished. This is the ECOG-PS tool, which is used in the oncological setup in order to assess the performance status of the patient. Coming on to the next part of physical examination, we look for pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. In pallor, we can examine areas, mucous membrane or nail bed, and whenever pallor is visible whenever the hemoglobin is less than 10, and pale palmar creases appear whenever the hemoglobin levels go less than 8. Interest can be assessed in skin, sclera, mucous membrane, nail bed, and clinical jaundice appears when serum bilirubin is greater than 2 milligrams per deciliter. Clubbing is assessed in nails, that is in the nail, in the angle between the skin and the nail bed, that is a lower band angle. The diseases causing cardiac or respiratory insufficiency might tend to have this finding. Cyanosis can be examined in skin, mucosa, nail bed, and also assessed based on the warmth of the extremities. It can be either central, peripheral, or mixed. Lymphadenopathy can be assessed in the main, some of the main areas to examine the main lymph node groups, including the cervical lymph nodes, axillary lymph nodes, inguinal lymph nodes, and abdominal lymph nodes. The inference could be either there is an infection or inflammation, or it could be because of lymph node metastasis, as is seen commonly in oncological setup. And the last part is edema. It can either be generalized or localized, as seen in just around the feet or sacrum. And it could either be pitting or non-pitting type. And based on the type of edema, we can further narrow our findings. Moving on to systemic examination. We traditionally do a para-abdominal examination, respiratory system examination, cardiovascular system examination, central nervous system examination, and musculoskeletal system examination. And based on the complaint, we tend to focus on or give importance to particular organ systems. As is the case of this patient, she presented with complaints of pain mid and lower back. So, and we have, as there is evidence in PET scan of extensive axial and appendicular skeletal metastasis, we need to do a clear, extensive central nerve system assessment. We need to rule out for deficits, motor deficits or central deficits, so that we can find out if there is a risk of impending malignant spinal cord compression, and take measures to prevent, take measures to prevent, if any, if there are signs suggestive of an impending spinal cord compression. The other system that we would focus in this patient would be the respiratory system, since she has presented with complaint of shortness of breath as well. And we will briefly go through the rest of system examination for this patient as well. So routinely, in our clinical practice, as is our practice in medicine, we'll do inspection, palpation, percussion, and auscultation in each system. But with the advancement of technology and availability of resources, and with the expert guidance from faculty, nowadays we are also able to routinely incorporate ultrasonography for doing examination, and also it comes to our aid doing various interventions. So once the history physical examination is completed, then we move on to summarization, and that is the summarization of the entire history taking and physical examination, and we can come out with probable differentials. And in our setup, in palliative care setup, we need to make plans, that is a treatment plan and care plan for the patient. And the next step that comes is prognostication. With the information that we have taken out from history and physical examination and other tools, we need to prognosticate whether it is regarding diagnosis or whether regarding progression of disease. And there are various tools that will aid us in prognosticating the patient and caregivers as well. Coming back to the clinical scenario, the patient has presented earlier to us with acute symptoms. Now, the rest of the treatment history is that she was reassessed in 2021, and at that time there were findings suggestive of brain metastasis, and she underwent whole brain radiotherapy in August 2021, and she was started on the next line of chemotherapy. And in January 2022, she presented with complaints of vigorous jerky movements of all four limbs, which was diagnosed as focal motor seizures with generalized tonic-clonic seizures, and on evaluation There was increase in size and number of metastatic brain lesions, which was suggestive of progressive disease, and she was started on targeted therapy. There was treatment history of again being hospitalized in October 2020 with the same complaints, and she was conservatively managed with anti-edema measures and anti-epileptic drugs. As of November 2022, she developed seizures refractory to both disease-directed therapy and anti-epileptic drugs, and she was stopped of all disease-directed management and was advised only for best supportive care by the primary treating team, in this case, the medical oncologist. But since the patient has been reviewing with us from the time of our first presentation, the transition from a disease-directed treatment to an exclusive palliative care treatment and supportive management was not difficult in this case. So at this stage, now so that the patient is at her terminal phase of a disease, end stage of a disease, and she has been declared only best supportive care to be done and no longer being a candidate for disease-directed therapy, we need to establish the goals of care at this point. There should be clear, compassionate communication, and in many cases, such discussions could have already taken place, and it should be a comfort-focused plan, and we need to discuss regarding advanced directives at this point. Elements at end of life include good symptom management and avoidance of suffering, and care that is consistent with the clinical, cultural, and ethical standards, and clear decision-making process. So there are many decisions that are to be taken at the end of life, including decisions regarding CPR, deactivation of cardiac implantable electronic devices, if any, the place of death, that is where the patient wishes to spend the last few hours to days of her life, the decisions regarding organ donation, and various cultural and religious traditions. So at this point, at the end of life, there are some tools that will help us in prognosticating the patient. Often the caregivers would probe us with questions like, how long does my patient have? So this tool will help us to give them an average time, and also help us assess the patient and see how much time the patient might have. This is the palliative prognostic score, and based on this, based on the 5 domains, a scoring is being given, and with this prognostication score, we can make out a score from the palliative prognostic index. Here the palliative prognostic scoring is involved. Other than that, delirium, dyspnea at rest, oral intake in the patient, that is oral intake, whether mouthfuls or less, or reduced intake but more than mouthful, or normal oral intake, and whether patient has edema or not. Based on these 4 criteria, scoring is being given and divided into 3 groups. In group A, that is with a score of less than 2, the expected survival is greater than 6 weeks. And in group B, with a score between 2 to 4, expected survival is between 3 to 6 weeks. And in group C, with a score of greater than 4, the expected survival is less than 8. So we can come out to an average expected survival, and with the help of this tool, we can prognosticate the attendants or caregivers. This is the education for physician on end of life care, EPEC, that has been provided by the American Medical Association. They have explained regarding 9 dimensions of patient assessment in palliative care, including illness, physical assessment, psychological assessment, decision making, communication, social assessment, spiritual, practical, and anticipatory planning for death. So we have already gone through all these headings that has been given. Holistic palliative assessment is rarely completed in one session owing to its complexity, and it frequently requires multiple meetings with patient and caregivers. The take-home message is burden of illness among palliative care patients is highly individualized, and therefore the methods of evaluation, including history taking and physical examination, should cater to their individual needs. And holistic palliative care is always an interdisciplinary approach. This is the pain form that is being routinely used in our practice. It has been developed by all our senior faculty and updated from time to time by our senior residents. This is the form that is being used in the OPD for a brief symptom assessment with more concentration over pain as a symptom. We initially mentioned the socio-demographic data, and since our department is in the oncological setup, this is catering to oncological diagnosis. When was cancer diagnosed, and details regarding the definitive therapy, whether done or planned to be done, and from where the patient was referred, and from which department the patient was referred to us. And it also includes relevant socioeconomic data, and also a body chart where the exact location of pain can be marked. And pain assessment, and this whole page includes assessment of pain as a symptom, and other symptoms can also be recorded at the next part of the form. This is the form that has been developed in our department by our senior faculty. We also have another, apart from the detailed history taking and physical examination, we have a daily progress sheet that has been developed 2 years back by our senior faculty and is being timely updated. Here also, this is attached whenever the patient gets admitted in the palliative care unit or the palliative medicine ward at NCA. In this also, we have the basic socio-demographic data, treatment the patient has received, and also the treatment intent, whether the patient is a candidate or receiving curative therapy, or the intent is only palliative, and also briefly explaining regarding presenting complaints and history of present illness and relevant negative history in the next column. And we have examination findings, a column for examination findings, and the scores of various tools that we have gone through, the DAS score, SGA, PPS, PPI, and if any relevant radiological investigation and bedside investigation, bedside ultrasound relevant findings, if any. And in daily assessment, we go through the progression of various symptoms the patient might be suffering, and also the vitals and important physical examination, and the treatment chart, investigation in the routine daily assessment of investigations. And there is a treatment chart where we monitor for drugs that are being given, whether there is any change made in the drugs. And in the final sheet, there is a final diagnosis to which we have come, the goals of care, the care plan that has been made, advice that was given, reviews, and prognostication. Prognostication notes are very important. We need to always document it as well. This is the progress sheet that has been regularly used in the IPD setup in our institution. Thank you, everyone.
So thank you, Revathy. Now,
Yes.
just tell me if Dr. Naveen Saleen has come as an examiner and he wants to know the brief history of this patient. So how
Yes.
can you tell the brief history of this patient, including physical examination, in 3-4 lines, so that he can have an assessment that what exactly you're talking. And then I request Naveen to take up her briefing of this case. Please go ahead.
Yes, ma'am. This will be the summarization as part of history taking and physical examination. Mrs. X is a 50-year-old female patient who has been diagnosed in 2014 with breast cancer, currently presenting to us with complaints of generalized body aches, predominant pain over mid and lower back with current NRS of 7 to 8 on 10, and another complaint of shortness of breath with MMRC grade 4. And she has been
anything else you want to summarize with the Dr. Naveen, so that he can have an idea that how we can make the treatment and goals of
as ma'am, as I've gone through the clinical scenario and stages, I don't know whether to summarize the first part or when the patient presented to us at the terminal phase. So
first part you summarize.
Ma'am, first part is what I summarized right now. The patient is a 50-year-old female.
No, I think you have said, but exactly that whether there was any significant family history, who has accompanied the patient, whom should we explain about the patient, Naveen, can you take answer this? Can you take up this now from Revathy? That what exactly residents should know from here?
Hello, can you hear me?
Yeah, we
Yes.
can hear you.
Yeah. Revathy, can you just repeat it once again?
Yes, sir. The initial presentation of the patient to us is at the time when she has completed all her initial treatment in 2014. But in 2020, she presented to us with acute symptom of pain, generalized body aches, but predominantly over the mid and lower back, with a severe NRS scoring of 8 on 10 at the time of presentation, and also complaint of shortness of breath on MMRC grading 3.
Okay. So, see, as Madam mentioned, you have provided the chronology, isn't it?
Yes,
I
sir.
feel that at this point of time, when we talk of any symptoms, because today we are mainly focusing on the symptoms, no? Three aspects of symptoms has to be focused. That is the difference between a medical history taking and palliative care history taking. That is one aspect of the symptom is intensity, which you are mentioning either through for pain through NRS or through other tool. But more than intensity of the symptom, also you need to mention about the impact of the symptom and the distress caused by the symptom for each of them. Now, for example, if the patient is breathless, you might use an MMRC grade to recommend the or to narrate the intensity of breathlessness. But we have something called as an oxygen cost diagram that provides a view on how the breathlessness is impacting the person. And there is an RDOS scale, although RDOS is very objective scale, but generally how it is distressing the patient. So I think that aspect is how it is different than a palliative care history taking. I'm just telling only from a symptom perspective,
Yes, sir.
which you should bring in.
Thank you, Naveen. So, uh, we have few comments on the. So this is from Preeti. Dr. Preeti, can you open your mic and say, because this is a whole paragraph, what exactly you want to ask? And then Punita, she's asking, uh, first extensively covered, can seniors guide us practical must tool in first PC evaluation and good to evaluate once for next visit, keeping time factor in mind. So, Punita, I can answer your before Preeti that whatever Revathy has explained in her this thing, this is the way we take history. I think we give a lot of importance to history taking and physical examination, and almost I think 30 to 40 minutes every resident is taking. But if patient is presenting with severe symptoms, I think we admit the patient, we relieve the symptoms first and then take the history afterwards, because this is very important that patient will not be able to tell you anything if he or she is in very severe symptoms. So this is what we do. And she has given in the, I think, last 3-4 slides that what exactly in palliative care evaluation definitely it should include. You can review these slides. This Divya is asking, while taking the psychosocial and spiritual history, do we have to use appropriate skills in the history taking or have to take it down in the patient words? I think patient words are most important, Divya. Definitely, skills are important, but if you really want to say that if this patient is depressed and if it is depression of a degree which you think that it is beyond physical suffering, definitely we would like to consult the expert. The skills will help you in that. But and other for research purposes, skills are definitely useful. So, Dr. Preeti, can you tell your comment, please?
Good morning, ma'am. Ma'am, I have one patient being referred to me by my colleague. She is 87 years of lady with severe varicose veins, neglected one and not willing to take any treatment. Now her pain is around 9 or 10 that she is even unable to go to the bathroom. what palliative care can I provide to her? She has already reached up to WHO level 2 and she is not willing to take any surgical, any other mode of therapy.
So you want to ask the treatment, what treatment we should give?
How should we go about it? Because it's all a doctor's mother and she is unwilling to take anything, but she has severe pain, bilateral lower limbs because of varicosities. She's 87 years and 100 kg weight, no other comorbidity, fully alert.
So now we are little deviating, but I will answer you. Deviating from the
Yeah.
topic, but definitely I will answer you. You
Yes.
should sit down with the primary doctor, maybe surgical person whosoever is treating her. You should sit down with them. You should discuss with them about the possible cure, whether any surgical intervention will help her. If they say that possible cure is not possible, or this general condition is deteriorating very fast, because if she is unable to walk and all, I think this her performance is not good, then we should definitely treat her pain. And for managing pain, I don't think any intervention will work over here, and we have to use our step 3 analgesics like opioids and all. We can take help of opioids for the time being, and once the pain is relieved, again we should assess this lady, that whether she would like to have to undergo any curative therapy, because because this is not a disease which we can leave. This can be cured if the proper treatment is given. But probably because she is in severe pain, unable to walk because of pain, she is denying treatment. So we should relieve her pain first, and then again we should assess her whether she is ready for the any definitive treatment. Again, go back to the surgical people and talk to them that now please talk to her, and if anything curative possible, please do curative. And all the treatment which you have started for severe pain, we should be very careful that once the curative treatment is started, she started improving, we have to reduce slowly and completely also after some time if she has been cured. Is it okay? Your
Exactly.
answer?
Was whether to move on to the next ladder or not, because all
No,
the
you
family.
can go. You can. No, your severe pain. If patient is having, she will not be able to decide the treatment plan and anything. And even the daughter will not. Even if she is a doctor, then also there will be so much of stress, psychological burden.
That is why I put.
So
Thank you so much.
okay.
Thank you.
Okay, good. Any other question, doctor? Anyone wants to have any comments? Dr. Jennifer,
Ma'am, I just want to
Would you
add
like
on,
to
ma'am. Sometimes when patients refuse certain treatment or something, it's important to find out why. Because they may be deciding from some past personal experiences or experiences from their friends or relatives. So it's really important to find out why they are against certain treatment and then motivate them. Otherwise, whatever we say will not make sense, and they will be just hanging on to that one particular unrealistic or a fear that is not right at all. The second thing about the history taking, which came out, which is very good. It's important to hear from for us, for palliative care physicians, history taking is like our diagnostic, meaning for all medical doctors, history taking is very, very important. But for us especially, it is like a diagnostic tool and an investigation, because we limit investigations to what are absolutely essential. We don't want to add financial toxicity, time toxicity. So much can be got from this history taking, which is and physical examination, which are very important tools. So we should use that well. And also we are looking at suffering beyond we are looking at symptoms and what is the cause, but also we are trying to understand patient suffering. So that is why the point that Dr. Naveen pointed, the impact of any symptom. So what is happening to you because of this symptom? They might say what they were not able to, what they were doing, which they're not able to, and how we can work on these certain aspects to improve quality of life. So understanding distress and suffering that comes out of these symptoms is also important. Thank you.
Thank you, Dr. Jennifer. I think this is an important. Yeah, go ahead, please.
Yeah, please finish your sentence.
No, thank you. Dr. Reena, please go ahead.
No, I'm Dr. Nandini.
Acha, Nandini.
I just want to elaborate a little. All these are such important points that I felt it has to be emphasized that, we are the biggest tool. We are presence with the patient. We should be worthy of their history with their mind, the space, everything. And that is when, as Jennifer said, we have history as the most important investigative tool. So if we are present there, we'll also pick up not only what they say and what, also the non-verbals are picked up there. And then our history proceeds based on the non-verbals too. So that is an important point to, emphasize. For example, okay, this happened, and then what did you do? We can also add, and then, so how did you feel? So, we need to keep on building up the actual, all the physical, emotional, social, all those things which are happening in the patient's and family's head through our gentle, history taking, through very active listening. So it is not just about list of tools, it's also about we as the tool. I wanted to emphasize. And also, as Jennifer said, we do routinely, if the pain is severe or any other symptom is severe, the social and other aspects are staggered in the sense that we are prioritizing some level of physical comfort so that the family is also a little more trust, they trust this team, they are open, they are very happy to continue to have conversation. And then our medical social worker counselors step in to have a detailed social and psychological history. Although psychological history quite a bit comes out in our discussion itself, but the detailed assessment comes much later. Thanks.
So thank you, Nandini. I think rapport building with or confidence building with the empathetic communication and taking clues from non-verbal clues. I think it is also very important. Very important point. Thank you.
Can I speak?
Uh,
This is Sushma.
Dr. Punita is requesting. Okay, when do we apply non-pharmacological treatment? Okay, so I think there are no other comments now. Who
Sushma,
has
Shobha
raised his
here.
hand?
Can I
Yes, please.
can I speak?
Yeah,
Shobha
please.
here.
Yeah, Shobha,
Yeah.
go ahead.
Yeah. So thank you for this wonderful presentation in the first place. And like everyone said, the importance of history taking cannot be overemphasized. But I think the most important part is to, just be with the patient, spend time with the patient, just hold their hands, talk to them in between, just go and ask their welfare, and you get, all tidbits of their history and their past history, etc. So we keep telling our students to do that. Just be with the patient, just hold their hands. You get the holistic history by doing that. Like Nandini said, how do you feel and what happened during that time? So that is very important. The other thing that I wanted to say was there are certain treatment decisions which the patients are not very clear about, but the oncologist would have planned, or some other specialty would have planned. And sometimes we need to be a liaison between the treating department and our patients. So it's not only the admitted patients that we see, as everybody would agree. It's the referred patients. We often see them much more than the admitting team, to be honest. And then they get confused, like who is our treating team kind of a thing. So we need to explain. We keep explaining to them that we are the supportive team. But we do act as a liaison between the treating team and the patient. So our postgraduates keep calling their postgraduates and ask, like, what is update? Suppose a patient has come with peripheral vascular occlusive disease. So are they planning bypass? When is it? And what is the hindrance? And when can we be taken, and those kind of things? Or are they just going in for prostaglandin infusion? So most of the times the patient is not very clear on that. So and the treating physicians also do not have a clear plan. So if we discuss with them, that helps in actually making a decisions. That's what I wanted to say. Thank you.